So for this session, we'll be talking about hepatocellular diseases affecting the parenchyma of the liver. So for our learning objectives, we will be hoping that at the end of these two sessions on hepatocellular disease and also cholestatic disease patterns, we'll be able to define cholestatic and hepatocellular liver disease and also provide examples of both and be able to interpret panels of liver tests. Also to define the difference between intrahepatic and extrahepatic cholestasis and outline approaches to distinguish these two, and define the pathophysiology of representative cholestatic diseases, including drug-induced cholestasis, primary biliary cirrhosis, primary sclerosing cholangitis, and bile duct obstruction, and develop an approach to the evaluation of the jaundice patient, define acute and chronic hepatocellular liver disease, and provide representative examples, provide the differential diagnosis for a patient with liver tests indicating hepatocellular disease, and discuss an approach to definitive evaluation. And finally, be able to interpret serologic tests for hepatitis A, B, C, D, and E with regards to the diagnosis of viral forms of hepatitis. So in general, we have two common types of liver disease. One is hepatocellular disease, and the other is your cholestatic disease. Your hepatocellular diseases refers to injury to the liver cells, particularly your hepatocytes, leading to necrosis or apoptosis, as the case may be. So the consequences of this injury will lead to either decrease in synthetic or metabolic activity of your hepatocytes, or because of the rupture of the integrity of the membrane of the hepatocyte can lead to release, no, of intracellular contents, including your transaminases, your AST and your ELT. On the other hand, another common type of liver disease is your cholestatic liver disease. So in cholestasis, you have a problem of impaired bile formation, either because there are problems in the production within your hepatocytes or absorption of materials of your hepatocytes. There can also be impaired bile flow, like there's obstruction in your bile ducts or in the duct tubes, depending on the anatomic location of the obstruction. So the consequences of this bile, either impairment of formation of the bile or impairment or obstruction in bile flow, will lead up to the buildup of blood substances, no, in the blood that are normally excreted in the bile. So, for example, uh, what will accumulate, no, will be your bilirubin and your bile acids because they are not excreted in the bile to the blood. Also, it can be a situation where there will be release of or synthesis or release of apical membrane protein, so that, for example, your alkaline phosphatase in the wall, no, of your sinusoids can be released, no, into the bloodstream. Your liver disease can also be considered either as acute or chronic. So aside from being categorized as either say hepatocellular or cholestatic form of liver disease, you can also categorize it as either acute or chronic. Usually acute liver disease refers to days, weeks, and months. So usually about less than 6 months, no? Acute onset of disease formation involving the liver. So for example, acute hepatitis will refer to an onset of inflammatory condition lasting less than 6 months. So your acute conditions can be due to injury to either your hepatocytes or to the bile duct cells, not the wall that lines your bile ducts. Chronic diseases, on the other hand, refers to a condition that affects your liver more than a few months to years, no? And the injury, the repair, and fibrotic process can take a long time. And this repeated pattern of injury, repair, and then fibrotic formation will lead to scarring of the liver, or what we call cirrhosis. And this is what leads to uh, problems, no, in chronic liver disease. So when you have cirrhotic liver, of course, scarring will make the liver non-functional. There are many etiology for chronic liver disease, and some of this etiology may be obscure or unknown and still under investigation. So when you are faced with a patient that is possible to have liver disease, you can either categorize that as a cholestatic disease or a hepatocellular disease. If you have cholestatic disease, you're looking at possible injury or trauma to the biliary tree, while if it is a hepatocellular disease, it affects your liver cells, specifically your hepatocytes. So if you have a cholestatic disease, the predominant liver tests that are abnormal will include primarily your alkaline phosphatase that are usually on the walls of your bile ducts, or bilirubin elevation. If you have hepatocellular disease, then the test abnormality will include elevations of your transaminases, your AST and your ELT, and to a certain extent, your protein and your albumin. So let us now go to hepatocellular diseases. So hepatocellular diseases are often termed hepatitis. So this is what we commonly call hepatitis or liver inflammation. So the term hepatitis denotes inflammation of the liver. No? It is applied to a broad category of conditions in a clinic that results from the damage by viral, toxic, metabolic, pharmacologic, or immune-mediated injury to the liver. So I hope that you can take the time to read your reference textbook on pathology, no? Basic pathology, and take a look at uh, this condition, how it is explained, the pathophysiology of your liver diseases, and it will be very useful for you to uh, take those materials into consideration. So these diseases, which we refer to as hepatocellular diseases or hepatitis or liver inflammation, are diseases that predominantly attack or destroy your hepatocytes. So they eliminate, they destroy, they injure your hepatocytes. And of course, because the hepatocytes are your primary functional liver cells, and destroying these hepatocytes will lead to derangements, no, in terms of the function of the liver. Characteristic laboratory test of normality will include elevations of your AST and your ALT or your transaminases. Now, in your histology, you have been taught the normal appearance of your liver. So you have the normal appearing portal tract in this condition. You have your normal appearing hepatocytes, and of course, the different sinusoidal structures that can be seen, no, in the portal triad. However, if you have hepatitis, you will have conditions where you will see inflammation, usually with necrosis of liver cells. So necrosis, you will see that there is a high staining, no, of your hepatic cells, and you will have infiltration of lymphocytes into the parenchyma. So there's an intense staining and lymphocytic infiltration into the parenchyma, as indicated in this slide here, will be seen, no, in your examination of the liver. Also, your portal tract will have an excess infiltration of lymphocytes also. So this uh, eosinophilic staining, no, uh, basophilic staining of your lymphocytes will be obvious, no, will be obvious to investigation. So your uh, hepatocellular disease can also be measured in terms of severity, and severity of damage or injury to the liver cells will depend on the extent of necrosis and damage to the number of hepatocytes in the cell. And of course, the extent of liver dysfunction will depend on the amount of functional hepatocytes that have been affected, no, by these hepatocellular diseases. Your clinical symptoms of acute hepatocellular disease can also be non-specific at times, but there are also some conditions, no, that refer, no, that could point to the presence of your hepatocellular diseases, of course, including jaundice, which is with problems with the liver and your bilirubitin. Of course, the time course either will be acute or, chronic. No? And etiology, of course, we usually associate hepatitis with viral hepatitis. So we have a lot of of these patients showing up in our clinical practice that shows damage from the five hepatotropic viruses that causes acute viral hepatitis, from hepatitis A, hepatitis B, hepatitis C, hepatitis D, and your hepatitis E. So we'll be talking about those viral form of hepatitis later. But remember that there are also non-viral causes of hepatitis or inflammation of the liver, and they could be due to the presence of toxic substances, like acetaminophen toxicity or ingestion of substances that damage the liver. Specifically, you could also have metabolic derangements. You could also even take drugs, no, that can destroy your liver, like your rifampicin, your rifampin. These are drugs, no, that can affect the liver and injure it, or you could have immune-mediated injury to the liver. So then, how do you assess, no, the extent of damage to the liver cells, particularly your cell necrosis? As we have mentioned in a previous session, you can assess the extent of liver cell necrosis by looking at EST or ALT elevation that provides certain clues, no, as to what is the number of liver cells that were injured or that died yesterday. As we have mentioned earlier, in our previous sessions, EST-ALT elevations are, reflective of acute processes, no, of 1 to 2 days, a picture of injury to the liver. So the variables that determine the AST ALT levels include the rate of death of your hepatocytes. Of course, the number of hepatocytes dying will be proportional, no, to the level of your EST or ELT elevation. So the production of EST, or the presence of ELT and EST elevation in the blood, is proportional to the number of dying hepatocytes. However, also remember that your reticuloendothelial system, your macrophage, eliminate quite efficiently the presence of EST and ALT in the circulation, and within a matter of 1 to 2 days, they can be eliminated from the circulation. So therefore, we can only say that the AST ALT measures, levels can only approximate 1 to 2 days of liver damage, because after that they are easily cleared from circulation. Going to the second question of how do you assess severity of liver dysfunction? Remember, dysfunctionality of the hepatocytes is not directly related to the rate of destruction, because it refers to the reserve of the hepatocytes. Because if it's just the damage is just occurring in a few days, then of course we know that the liver has a large reserve, and so therefore functionality will not be affected. So then how do you assess liver function? So there are certain variables that you need to take a look at to assess your liver function. Liver function is determined by the number of functional hepatocytes, which is the sum, no, of your hepatocyte dysfunction, or the number of sick cells, your hepatocyte death rate, plus the duration of the disease, plus of course the regeneration rate. Remember that your liver has a rather unique characteristic of being able to regenerate itself. No, it's an organ that can regrow after injury, because there are reserved cells, no, within uh, the spaces within the liver that can regenerate injured hepatocytes. So how do you then assess impaired liver function? So these are some of the measures that we use to take a look at impaired liver function. One is your protein synthetic function. The other is your organic anion transport. The other one is your glucose production. And the fourth one is your urea synthesis. So together, these four tests can somehow approximate the extent of impairment of your liver function. So for this specific measures for protein synthetic function, You take a look at your pro time. So you will have, typically, if you have impaired liver function, you will have increased prothrombin time, and you will also have low albumin. So because your prothrombin time is dependent on your vitamin K dependent factors, clotting factors, then your pro time will be increased if they are affected, no, if the hepatocytes are affected. Also, your albumin is produced by the liver, so therefore, low albumin will refer to impairment of your liver function. Secondly, looking at your organic anion transport function, which involves bilirubin. So if there is accumulation of bilirubin, if you have hyperbilirubinemia, this could also point to impairment of liver function, and this is more or less specific compared to the other tests. Glucose production is also another measure of impaired liver function. If you have hypoglycemia, so a patient that comes in with hypoglycemia, one of the differentials will be impaired liver function. However, typically your hypoglycemia is a late finding that occurs in a patient, and therefore, if you have or suspecting a patient with liver problems and it shows up with hypoglycemia, then that condition is already there for a long time because this is typically a late finding. Your urea synthesis is another measure for impaired liver function, and the elevation of your ammonia leading to hyperammonemia can lead to hepatic encephalopathy, and this is one of the conditions which you want to avoid in your in your patient with liver disease, because this can lead rapidly to death of the patient. So you need to manage, hyperammonemia that can lead to hepatic encephalopathy and can lead to neurologic deficits and eventually to affecting the central nervous system, leading to coma and eventual death. So these are ways by which you can provide a picture of the level of impairment of your liver function. Now, as we have mentioned earlier, your acute versus chronic hepatitis is characterized by differences in the time course of the disease. So acute liver disease usually is associated with less than 2 to 3 months of disease process. And this usually heals completely due to hepatic regeneration. So acute hepatitis, acute injury to the liver, usually with less than 3 months, can be healed completely due to the presence of regeneration of your hepatic cells. However, chronic diseases are persistent liver disease more than 6 months, and as a result of the chronicity of these disease patterns, can lead to the development of fibrosis that can lead to cirrhosis, and then of course the complications of cirrhosis will lead to eventual liver dysfunction and liver failure. And another condition that can be the consequence of your chronic hepatitis is the development of liver carcinoma or hepatocellular carcinoma. So cancer of the liver can also be due to cirrhotic conditions or can be due to chronic conditions uh, affecting the liver. So what are the clinical symptoms in acute hepatocellular diseases? So usually they are asymptomatic, patients that are asymptomatic. However, they can have abnormal liver function tests like elevated transaminases in the blood. You could also have jaundice, but they can be non-specific symptoms like fever, nausea and vomiting, also fatigue, physical findings of jaundice, as I mentioned earlier, uh, liver that is standard to palpation. You could also have altered mental status, and even coma, especially in relation to your hepatic encephalopathy or accumulation of urea in the blood. You could also have bleeding. Because of course you know that your liver is involved in the production of your clotting factors, especially your vitamin K dependent factors. And you could also have other uncommon symptomatology, including headaches, myalgias, arthritis, even rash, urticaria, and arthritis can be associated with acute hepatocellular diseases. So the symptoms associated with your acute hepatitis are due to the release of your inflammatory mediators, particularly your cytokines, your tumor necrosis factor, and this can lead to presence of fever, myalgias, fatigue, and nausea. So take a look at this uh, pathophysiology of the release of mediators. of inflammation in the liver in your pathology textbooks. Liver dysfunction can also lead to bleeding, of course, because we know it's involved in the production of protein, of coagulation factors. It could lead to jaundice because of the derangement in bilirubin production, excretion. It can eventually lead coma due to the presence of hyperabonemia. And because you could also have immune complex mediated diseases that can lead to the symptoms of rash, urticaria, and even presence of arthritis. So if you have just a mild hepatitis or mild liver disease, the AST/ALT elevation will be less than, let's say, less than 1,000. So maybe about 400 to 500 IU. Uh, and generally, the patient is asymptomatic. So mild elevation or EST or DLT can be indicative of mild hepatitis or mild hepatocellular diseases. However, moderate hepatitis is associated usually with elevations of your AST, ELT, your transaminases to more than 1,000 to about 2,000. And this can be associated with fatigue, with nausea, moderate jaundice. And however, your pro time can still be normal. No? So the laboratory test for pro time can still be normal in moderate hepatitis, even though your transaminases are already elevated. If you have a fulminant liver failure, where you have an acute condition that rapidly degenerates and eventually leads to death of the patient, you will see that in terms of time course, no, the elevation of your AST/ALT is very rapid, more than 5,000 AST/ALT levels is alarming, and if it occurs in a matter of days, associated with fatigue, nausea, vomiting, abdominal pain, severe jaundice, and elevations of your protein, it can eventually lead to your coma and death patients. So we have seen patients like this, not deteriorating in a matter of days, and it is due to fulminant liver failure. And there are several etiologic agents that can actually cause this condition, no, of fulminant liver failure. So your fulminant hepatic failure is defined as an onset of liver failure within 8 weeks after onset of new liver disease. So within 2 months, the patients can have liver failure, and of course, if the liver fails, it's just like death sentence for the patient. So this is defined by evidence of impaired liver function, such as increased protein, hypoglycemia, and even the presence of encephalopathy. No? This is caused by, specifically, if you have greater than 80% loss of hepatocytes, so more than 80% of your liver is damaged or dead, then there is no way for the liver to cope, no, or regenerate itself. And the mortality rate for this condition ranges from 40 to 80%. So the approach to patients that have fulminant hepatic failure generally is to immediately hospitalize them and consider liver transplantation. You have to be in a center where liver transplant can be done. Otherwise, the patient can die. And in the context of the Philippines, of course, especially if you are in the non-urban areas, conditions like this can generally lead to death of the patient because we don't really have much facilities aside from the big centers, no, for liver transplantation. Now, a chronic liver disease, on the other hand, involves the slow but persistent increase of your EST, ELT that is indicative of continuing injury to the liver, that tends to be low to moderate in intensity but are persistent in terms of months and years. Thus, your day-to-day symptoms can often be mild and even sometimes absent. So there are chronic liver diseases where the patient do not know that they have liver disease because they don't really have symptoms except for the slight elevation of their transaminases. And hepatic regeneration can usually cope with the injury to the liver, but this may not equal the level of injury. So they could either cope with the injury or they could not cope with the injury. So if they could not cope with the injury, eventually the liver will fail. So long-term chronic liver diseases, the new symptoms may arise due to the extent of liver dysfunction or as a consequence of cirrhosis. No, so if you have chronic liver disease, one of the consequences is the development of fibrosis, scarring of your tissues, leading to cirrhosis, where more and more of your liver is no longer functional because it destroys the normal architecture of your liver. So on your screen is a listing of the possible etiologies of hepatitis, either acute or chronic. So in the Philippines, the usual context of our hepatitis is viral. So we have 5 viruses that can cause viral hepatitis, from your viral hepatitis A to E. However, take note also that in the clinics you could also encounter autoimmune types of hepatitis. So generally, the problem is inflammatory condition. So you can also encounter autoimmune type of hepatitis. So you need to uh, take that as part of your differentials. Drugs and toxins can also be causes of your hepatitis, including alcohol that can lead to fatty liver disease or alcoholic hepatitis or cirrhosis. Drugs can also be sources of injury to the liver, including acetaminophen, rifampicin, and other drugs. Even so-called herbal medicine or Chinese drugs, Chinese traditional medicine. Some of them are toxic to the liver, so be careful in eliciting the history for intake of this kind of substances, no, or drugs in a patient if you're suspecting the patient to be suffering from hepatitis disease. It can also be genetic. So there are conditions where there are genetic predisposition, like your hemochromatosis due to the deposition of iron. You could also have Wilson's disease due to the deposition of copper. And of course, this is one that usually appears in examination. Your alpha 1 antitrypsin deficiency can also implicate your liver. Other problems can include metabolic form of hepatitis, that this is your non-alcoholic fatty liver diseases, or your NFA FLD. So this is very common now, even in the Philippines, because of our lifestyle and diet, high fat diet. So we have fatty liver diseases that are not associated with alcohol. You could also have hyperthyroidism, leading to metabolic derangements involving the liver. Problems involving the liver can also include your vascular supply, including ischemic problems. This can include your Budd-Chiari syndrome, your heart failure, which are due to obstruction of outflow of your uh, venous system in the liver. You could have decreased perfusion due to shock, and you could also have sinusoidal obstruction, for example, sickle cell disease, where there is elevated destruction of your red blood cells that can obstruct your sinusoids. So this can lead to ischemia. You also have infiltrating mass. You could have tumor, leukemia, and amyloid problems that can impair the parenchyma of the liver. And of course, you could also have bowel inflammation that can affect the liver, including Crohn's disease, ulcerative colitis, and your celiac flu. So all of these conditions, please take the time not to take a look at your textbook and understand the pathophysiology behind injury to the liver. So with that, for the next few sessions, we'll be taking a look at viruses, autoimmune hepatitis, fatty liver diseases. The other diseases, please refer to your textbooks, including your internal medicine textbook and your basic pathology textbooks. And other diseases will be covered by later lectures.